you as well. CART transcription is available, and I believe Kirsten will tell you a bit more about that in a few minutes. Finally, thanks to all of you who took that 10-minute pre-test quiz on SurveyMonkey. There will be a post-session follow-up quiz in order to try to assess how this training went, whether your knowledge has increased, whether or not the format we used is the best one possible. And we'll ask you to complete a short session feedback at the end of the day as well. With that, I will hand over to Kirsten.
Thank you, Kim, and thank you everyone for being here with us today. I'm really happy to have the opportunity to spend the next 90 minutes with you. So in addition to some of the procedural issues that Kim has just gone through, I wanted to talk a little bit about the steps that we've taken to ensure accessibility of the training today. So we've taken some really simple steps to make the PowerPoint accessible to people who may have more difficulty seeing, for example. So you'll notice that the PowerPoint, we've used high contrast colors. We've also used minimal graphics. And you'll also notice that as we go through the presentation today, we'll be describing any of the pictures, any of the non-text elements. We'll also share the slides with you afterwards. And when we share the slides with you, you'll see that we've also made the non-text elements accessible with text descriptions. So basically all of those features are helpful for people who may have difficulty seeing and use screen reader technology. Secondly, we've also made closed captioning CART available, and we shared the link with you earlier in the invitation. So closed captioning is a really important tool to help improve accessibility for all. It's often used for people who are hard of hearing or who have a learning disability. It's also useful for people for whom English is a second language. And we also find that the CART transcript is useful as a tool to pull out statements and to support reporting and planning after any webinar. So that's something we really try and do as a standard when we're delivering training. Secondly, I just wanted to talk us briefly through the objectives of the training today and let you know what we'll be doing. So as Kim has already mentioned, we'll be talking about how disability fits into the HNO HRP process. And we're trying to make this a very actionable training and to present some really practical tips for how you can ensure disability inclusion in the HPC. Mainly, we're just really aiming to demystify disability inclusion and to show that disability inclusion is not something that's overly technical or overly complicated. And many countries are already doing this really well. So it's just about taking those good practices and learning from them in other countries and making them more systemic. So on that note, we'll also be sharing a number of examples from the 2020 HNOs and HRPs that we've seen. Now, finally, as Kim mentioned, we're only with you for 90 minutes today, which is quite brief. It means that we won't be able to get into very technical details about issues like data disaggregation, but we hope that this will provide you with a really helpful starting point to be thinking about how we can strengthen disability inclusion. And at the end of the training, we'll also be sharing with you a number of resources that you can use to further help support this work, including a guidance note that we've already shared with you previously and that much of this content has been based on. So I will hand back to Kim.
Thanks a lot, Kirsten. We are going to start out with some questions that really inform the work that we're trying to do here. So, Steve, can I ask you first, why is disability inclusion particularly important in the HNOs and HRPs?
Well, thanks, Kim, for that question. What I'd like to do is turn that question around and pose it to the group. So what I'd like to happen is for the participants to use the chat box that you can bring up on your screen by pressing the chat icon. And could you out there in training land answer the question, why is disability inclusion important in HNOs and HRPs? Try to think that one through and come up with some rationales yourself and using the chat function. And we'll track that and then come back to you with some thoughts of our own. So you pull up the chat. Okay, so exclusion is unacceptable to ensure that no one is left behind, for sure. It's very early in the morning in New York, but it's probably later in the day in South Asia. So please please use this moment to participate. So why is disability inclusion important in HNOs and HRPs? Well, often, as we know, persons with disabilities are often the most in need and may be differently impacted by the crisis, by the humanitarian context. Often persons with disabilities have a heightened risk of violence, exploitation, or abuse. We know that persons with disabilities often have additional barriers they face in accessing assistance. You know, if they can't get through the door, if they can't hear communications, they can't know what's going on. Barriers can also include additional forms of discrimination and stigma. We know that accountability to affected populations is central to our work, and persons with disabilities also need to be considered in terms of accountability processes. It's important that actors doing humanitarian action make a conscious effort to understand that their response efforts need to reduce barriers to the extent possible. So there's a lot of reasons why disability inclusion is important in HNOs and HRPs, and what we're going to do is check against the comments that you've put in the chat box and track these. Can I hand it back to Kim?
All right, this is Kirsten. Just while Kim's sorting out the technical issues, perhaps I can pose a question to Ricardo. And that question is, we're talking a lot about why is disability inclusion important, but actually who are persons with disabilities? Who is it that we're talking about? Ricardo.
Thank you, Kirsten. I'm Ricardo, and I'm working for UNHCR as protection officer and focusing on disability inclusion. And indeed, it's really important to understand better who are persons with disabilities, and in particular, using a rights-based approach so we can understand why it's important to focus or to include persons with disabilities in humanitarian needs overview. If we go to the next slide, please, Ahmed. We can see there is a diagram or graphic representing the concept of disability as conceptualized in the Convention on the Rights of Persons with Disabilities. In that concept, we see that on one side we have persons with impairments, but they are not by themselves considered as persons with disabilities in isolation. Disability is rather resulting from an interaction with persons with impairments, and on the right we have the environment, institutional, attitudinal, physical communication barriers, and that interaction can be positive or negative. If it's a negative interaction, then we have obstacles to participation and higher disability, and but we can have a positive interaction and result in inclusion. Why is important to have this shift understanding of disability? Well, first, because we will see that we are part of the environment. The programs that we are planning, the services that our organizations are providing can pose attitudinal barriers, those of our workers. There can be physical barriers to access our facilities. Our information can not be accessible, and that is increasing the disability experienced by certain persons. And with this, we need to understand what is said below, that disability is evolving. It evolves throughout the life of a person. It evolves throughout even the day of a person. And we are part of that interaction. We can make it positive or negative. If we go to the next slide, we will understand that it is as well important to consider persons with disabilities due to the the well, sorry, the percentage, but not only the percentage, the amounts. If I didn't want to use that word, but the impact that it has across the populations affected by conflict, by disasters, and even in humanitarian settings. What we see in the center, we see an infographic that is extracted from the Interagency Guidelines on Inclusion of Persons with Disabilities, and that uses data from the WHO report on 2011. The data says that it's 15% of the population having a disability, but persons with disabilities are not a homogeneous group. Another important factor to consider disability inclusion around on HNOs and HRPs. Their disability is an identity shared across a variety of profiles that are as well the responsibility of different mandates and different and of groups that require specific protection. For example, women, 1 in 5 women will experience disability, and we have that on the left side of the infographic. On the right, we have children. 1 in 10 children is a child with a disability. And then from the 9% of population that are considered to have 65 or over, half of this population have as well a disability. So the variety of experiences of disability should consider as well intersectionality. But in this infographic, then we have on the left and right side 2 different three different surveys that give detail on data and confirm a trend that we've seen in the last years, and it was mentioned already in 2011, and is that disability is usually the prevalence of disability is higher in context of humanitarian crisis and displacement. For example, on the left side on the top, we have the cover of a vulnerability assessment framework. That was an assessment not focusing on disability, but including disability and the Washington Group questions. And 21% of refugees, Syrian refugees living in Jordan, have a disability, with over half of the households having at least one person with disability. In Syria, OCHA coordinated a countrywide disability prevalence study, which is on the left side of the screen, and 27% of the population in Syria have a disability. But if you go to the study, and for example, the protection cluster in Syria has made use of this in this year when analyzing the impact of COVID, you will see that, for example, women with disabilities in Aleppo are over 60% of the population. Or arrive almost to 60% of the population. Older persons are almost 100% in certain areas have as well impairments that could be considered as living with a disability. And to finish this, on the right side, we have a survey conducted in coordination with WHO and the Asia Foundation in Afghanistan, and that survey as well represents a higher percentage. Richer in this type of data, we have 13% or almost 14% with severe disability, but to that we should add a 65% with moderate and mild disability, and children with disabilities are as well higher with 17.3%. That to say, the percentage in displacements populations, but as well refugees, and I see the question. Well, Jordan would refer to Syrian refugee, for example. Thanks to the contribution of all of you, of all the people that has been gathering this data and sharing this data, and hopefully more data will be available in more countries if we all coordinate that work, has shown that the prevalence of disability is really higher in humanitarian contexts. We've mentioned already that there's barriers that we can ourselves put to our services. There's increased risk, but I would like to go back as well to a comment in the chat box that is about rights. Persons with disabilities are part of human diversity, and as such, they are as well, they have a right to be protected and to access humanitarian services. So that would answer as well the question of why disability inclusion is important. So I'm giving back to Kirsten. Thank you, everybody.
Hi, Kirsten. I'm back online. My apologies for all of that. So we have another question that's quite interesting. Do persons with disabilities experience humanitarian context differently? And as we noted yesterday, I would add to that, perhaps how do people with disabilities experience humanitarian contexts differently? Over to you.
Thanks, Kim. And it's a really important question. And I would say first that the short answer to your first question on do persons with disabilities experience humanitarian context differently is absolutely yes. What we often see in HNOs is a recognition that persons with disabilities are more vulnerable or they're at heightened risk, but what we rarely see is an analysis of why. So as you also mentioned in your question, that what we really should be asking is how do persons with disabilities experience humanitarian emergencies differently, and also why are they at heightened risk? Now, while the same hazards impact on all members of the community, people with disabilities experience them differently because of the barriers they face and because of intersecting structural inequalities. So we developed a simple diagram onto the next slide. Yep. So we developed this really simple diagram to describe the factors that contribute to the risks faced by persons with disabilities. And the key point that this diagram makes is that persons with disabilities are not inherently vulnerable. The heightened risk that they face is directly due to the barriers that they experience and intersecting structural inequalities. And I'll just very briefly go through a simple example of a flood to demonstrate what we're talking about here. So basically, if we're looking at the top of the diagram, the hazard is the flood, and this is the same for everybody. The hazard is that the river is bursting its banks. We then go further down in the diagram into impacts, and we again look at the impacts for everyone. So the impacts are things like the bridges wash away, it's difficult to move around. Families need to move to higher ground, crops are destroyed. These are things that are experienced by everybody. But as we move further down into the diagram, we start to look at how do persons with disabilities experience these impacts differently and why. So one of the key things we need to be looking at is barriers at the center of the diagram. And so taking the flood example, somebody who has difficulty hearing, if early warning systems are only over the radio and loudspeakers, people with hearing impairments won't be able to hear those early warning systems. For somebody who is blind, if information about escape routes is on signposts, they're not able to see those and they're not able to safely escape. If we then look at the right side of the diagram in that centerpiece looking at barriers, even within the population of persons with disabilities, there are people who will experience barriers differently. So for example, older people may be less valued by communities due to that intersection of age and disability related stigma. So they may be rescued last. Women with disabilities may face compounding barriers to accessing wash facilities in shelters due to an intersection of both gender and disability related obstacles. And in that list of intersecting identities, we could also add, for example, refugee status as an intersecting identity, where refugees with disabilities experience the impacts differently because of the combination of their disability and their legal status in the country. So if we then move to the bottom of the diagram, the heightened risk faced by persons with disabilities, we see that it's directly as a result of those barriers and intersecting inequalities that people with disabilities face heightened risks, such as being left behind, facing higher levels of SGBV in shelters, for example. And as mentioned earlier, these risks aren't inherent. They were created by the various barriers and by the age, gender, disability, and other related discrimination. So the key point that this really simple diagram makes is that to be able to address those heightened risks at the bottom of the diagram, we first need to clearly understand what are the factors that contribute to that risk, because it's those factors that should be the target for our intervention rather than merely identifying what the end risk is. What we often see is it's this middle step, this identifying the why, identifying the contributing factors. It's often that middle step that we see being missed a little bit in needs assessment processes, but it's really key to conducting an analysis of the needs of persons with disabilities. So what I will do now is hand back over to Ahmed, because he's going to take us through a practical exercise that we'll do to practice this middle step in relation to COVID. Back to you, Ahmed.
Thank you, Kristen, and thank you for explaining this analytical model of vulnerability. And actually, our practice test or our group working will be around the same model. We will use the same model to analyze how a person with disability is experienced differently COVID-19 within humanitarian context. As we all know that most of HNO HRP, the next cycle of HNO HRP will consider heavily how COVID-19 is interacting with that. How we will do the exercise? The exercise will we will divide ourselves to three groups. We will use breakout rooms. Zoom have this ability. I'm sure that most of you have tried before. I will automatically send you to a group of 20 in 3 breakout rooms. Group 1 will have to work in direct health. I will send shortly a Google document that you could work together with. Group 2 will work in indirect health impact of COVID-19, and Group 3 will work in socio-economic. In every group you will have, I will be with Group 1, me and Ricardo in Group 1, Steve will be in Group 2, and Kristen will be in Group 3 to support the process and fill down the table. So how we will do it? We will apply the model of that we have seen now with Kristen on COVID-19 and disability. As you see, we will try to fill this table together as a group. The COVID-19 is the hazard that is existing in the up of the model, which lead to a socio-economic or health or indirect health impact according to your group. The impact will be, we want only to detect 3 impact points, right? 3 points, try to use a simple language because of the time. We will also try to identify what exact barriers person with disability is facing in this situation of COVID-19. Try to link it to the socio-economic or health or indirect health impact according to your group. Write one only barriers in every example, and the same will be in intersectional identity. How the intersectional identity like age, gender, or poverty is affecting how person with disability is experienced differently the impact of COVID-19. Then we will see to which extent this is heightened the risk that is faced by persons with disability in the humanitarian context. My colleague Steve have sent the 3 rooms. I will form the room now. As I said, the room you will have in the room nearly 10 minutes. 1 second. And then I will send you to this room. Once you enter the room, you can access the document, the Google document, and you will be able to work on it. Thank you. See you in the rooms. I think we are backing.
Yep, we're back, Ahmed. Thank you.
Yes, thank you. I hope it was a very interesting discussion, and I hope that everyone had a good one.
So Ahmed, Kirsten, Steve, I know that the group I was in had a very interesting discussion. I wonder if we might ask the three of you to feedback on some of the points that were raised in each of the groups, looking at, what are the heightened risks that we need to be aware of when we are looking at developing these HNOs and HRPs and associated programming. Over.
Thank you, Kim. If you allow me, I will start with direct health impact group. Actually, it was a very interesting discussion, and we didn't have enough time to fill everything, but I think the idea was there. We agreed that using this kind of model need to be proactive dynamic. That means that we are usually try to link how the specific impact is affecting by specific barriers and leading to a specific heightened risk, and also agreed that vulnerability is not inherited by person with disability. That means that, and actually the group have highlighted that very much, that to be careful not to using the excuse that the person with disability have a precondition or the existing situation of person with disability, just to say that they are only vulnerable because of that. We need to understand also how the environment and the barriers and the policies and the system is leading to that. And I think this is a very important issue. We have talked about the impact of direct health, how they have heightened exposure to infection to COVID, and difficulty, of course, due to social inability to observe social distance, risk of serious illness due to infection, and higher mortality rate. We discussed about barriers. We discussed about the attitude also, but we didn't write in it. We discussed about inaccessibility to healthcare and WASH. Discuss about lack of policies and measures to allow access to oriented institutional support for persons with disability and other vulnerable groups. We discuss about communication, inaccessible information, and communication to prevention. Unfortunately, we didn't have time to discuss the intersectional identities, but very shortly we talk about age as one of the factors that is increasing person with disability who have a high age, or person with high age, or older person that is having most of them having disability, which lead to increased risk of COVID. And then we talk shortly about heightening the risk, for example, more difficulty to exercising preventing measure due to inaccessible information or discriminatory practice in decision-making process. I'm trying to summarize it in very short time, but the group have a very, very interesting ideas that I'm sorry if I cannot capture it all of it. Thank you. Back to you, Kim.
Hi, Kirsten, Steve, did either one of you want to come in with some points from your groups?
Sure, Kim, thanks. Our group found our way to the room eventually, and found our way to the right page to look at eventually, and I think we had a good discussion. I mean, we're trying to get our head around the indirect health impacts of COVID on persons with disabilities, and one of the points that I think is an interesting one is that, you know, in a low resource setting where the health system itself probably doesn't have a lot of capacity, a global pandemic puts additional strain on it. So the kinds of services that persons with disabilities may have been, you know, accustomed to getting prior to the pandemic might be less available, less accessible. The lockdown in many countries would make it difficult for carers perhaps to have access to the persons that they were helping. But, you know, the freedom of mobility that would allow people to come in and assist each other breaks down networks. There would be issues around indirect health impacts in terms of communication barriers. the kinds of health information that the governments put out might be not in a form that's accessible to people with sensory impairments. A case from Central Africa was persons with disabilities may lack civil documentation, making it hard for them to actually access the healthcare that's available. We know that persons with disabilities have pre-existing conditions, and that possibly increases their mortality rate, making them more at risk. The economic crisis, the loss of livelihoods, might make it more difficult for persons with disabilities to afford healthcare. And so there are a number of things that we could think through in terms of indirect health impacts that have a bearing on persons with disabilities in particular. Kirsten, did you have anything else to add?
Yeah, thanks, Steve. We also had a really interesting discussion in our group. There's never enough time for these kinds of discussions, is there? But people were reflecting on what they're seeing in their context, which was very helpful. The main two impacts that we talked through was loss of employment and closure of schools. And so some of the barriers that we talked about impacting on persons with disabilities were perceptions that people with disabilities are not productive. So they're deprioritized, for example, in livelihoods programming, and also deprioritized where there's rationing of services. We also talked about communication barriers like inaccessible platforms for distance learning, as well as physical barriers to education. In terms of intersectionality, we talked about age, in that older persons with disabilities may be more restricted in the context of movement restrictions, both because of their age and disability, and same for children with disabilities. There were a number of points that were raised in relation to the intersection of gender and disability. One of them being, for example, that boys with disability, boys may be prioritised for schooling over girls. And that also extends to within the household, which children are receiving support in the context of distance learning. So girls with disabilities in that context are doubly disadvantaged, both due to disability and gender. And so some of the heightened risks that we highlighted were that children with disabilities are often the first to drop out of school in the context of school closures, and also the higher levels of poverty that people with disabilities are facing as a result of the crisis, which impacts their access to services and also impacts their access to basic commodities. Just as the time was ending, we were getting into a really interesting discussion on social unrest and how people with disabilities differently experience social unrest. So hopefully that's a conversation that can continue offline. Thank you.
Thanks very much to all three of you. So as we move forward, how do we use this? How do we use this new knowledge that we have to include disability more effectively within the humanitarian needs overview process? Over.
Thanks, Kim. That is a question for me that I will take up. So basically, I'll just talk us through very briefly some of the key tips that we have for including persons with disabilities in the HNO process. And as mentioned earlier, all of this information is also covered in much more detail in the guidance document that we shared earlier and we'll do again. So firstly, just to highlight that when we're talking about inclusion of persons with disabilities in the HNO and HRP process, it's not something that we should be seeing as a separate step. So in the guidance, it's very much described as something that is inherent and central to all of the steps within the HNO HRP process, rather than being a parallel process. Next slide, please. Also, we wanted to highlight that when we're looking at inclusion of persons with disabilities in the HNO process, it's about more than just counting numbers. So one of the key steps is to agree on the scope and focus of the analysis. So in relation to persons with disabilities here, we need to be really asking ourselves, what do we need to know? What questions do we need to be asking in the needs analysis? And it's about more than what are the numbers of persons with disabilities. So firstly, we need to be looking at how do persons with disabilities experience humanitarian consequences differently. Secondly, looking at what are the factors that contribute to the heightened risk for persons with disabilities, And as part of that question, what are the barriers and facilitators to persons with disabilities accessing assistance? So as you can see from those kind of questions, we don't necessarily need to be doing a household survey to count numbers of people. We need to be looking at needs assessment data disaggregated by disability to see how people with disabilities do experience these situations differently. Focus group discussions and key informant interviews where we get to hear from persons with disabilities themselves are really important to get a more nuanced understanding of what are the factors that contribute to heightened risk. And barriers and facilitators assessments that, you know, we've seen done quite a bit, particularly in the MENA region, are really helpful to better understanding clearly the barriers and facilitators. As has been mentioned a few times throughout the training already, AAP is a particularly high priority, and we also need to be understanding what are the views and perceptions of persons with disabilities. So making sure that our AAP mechanisms are accessible. So it's just to highlight some of the questions we need to be thinking about at the outset of a needs analysis process. Next slide, please. Sorry, yes. I was going on to the next slide, but no, this one. So yeah, what we wanted to highlight here is also a good practice example that we saw in the Afghanistan HNO. And this was about where do you present, how do you present this information about persons with disabilities once you do get that information from the needs analysis. Now, what was done in Afghanistan was a separate section on disability where that information could really be explored in some more detail, in addition to disability being mainstreamed throughout other sections of the HNO. So we just wanted to share that as one good practice example, having that separate section on disability in addition to mainstreaming throughout. Next slide, please. So one of the other key messages from the guidance is that you don't always need to be going out and collecting new information. There's often studies that have been done in many contexts that are really, really valuable in terms of understanding what is the situation, the needs and priorities of persons with disabilities. So in our review of the 2020 HNOs, we found quite a few really good examples of different studies that had been done. And one of the key points I wanted to highlight here is how valuable it is to disaggregate survey data by disability. So we've seen some really valuable studies that are focused specifically on persons with disabilities. And Ricardo gave some of those examples earlier on when he was giving us information about numbers of persons with disabilities. But it may not always be feasible to conduct a disability-specific survey in your setting. And in that case, having disaggregated information on persons with disabilities in more general needs assessment processes is really highly valuable. So just to point out one example here, in Iraq, the REACH multi-cluster needs assessment in 2019 found that healthcare costs for households with a member with one or more disabilities are twice as high as those without a member with a disability. So that kind of information can be really valuable. Next slide, please. So we've been talking a lot about the importance of disaggregating data. So I just wanted to highlight very briefly the Washington Group short question set as a really key tool for disaggregating data by disability. Now, there's a lot more information about this tool in the guidance, so I'm not going to talk through it in too much detail, but just to highlight that in order to identify persons with disabilities, it's not enough just to ask, do you have a disability, or to use visual cues. And that's for a number of reasons. Firstly, for example, there's often very high levels of stigma against disability in many settings. So people with disabilities may not be willing to identify as having a disability, or their families may not be willing to identify themselves as being a household with a member with a disability. Also, there are very differing understandings of what disability means. In some contexts, older persons with disabilities aren't considered to be persons with disabilities. So for this reason, just asking, do you have a disability, is often not a helpful approach. And for that reason, this question set exists to identify people with disabilities. What's really valuable about this question set is it avoids any risk of stigma. It doesn't actually mention disability in the questions. It's also very simple and can be administered by people who are not experts on disability inclusion. So one of our key recommendations would be to integrate this question set into your needs assessment tools as much as possible. Just to take a very quick aside as well on disaggregated persons in need figures, disaggregated PIN figures. As you know, the HNOs, HRPs now require PIN figures to be disaggregated by disability. And one of our key recommendations would be that where you don't have reliable local data and where you don't have the capacity to collect primary data, to simply use that 15% global estimate. In many settings, as has already been highlighted in the chat as well, that 15% estimate is too low for your setting. And in that case, to also justify why you're using a higher estimate. But there's not always a need to be collecting that primary data. The last point to highlight on this slide is just that, again, it's not only about numbers, but it's also about ensuring that we get that qualitative information from persons with disabilities. So if we're looking at key informant interviews and focus group discussions, it's not enough to simply invite persons with disabilities to those processes. We really need to be thinking proactively about how to make them more inclusive. And one of the key actors to support us on that are local organisations of persons with disabilities. So these are organisations made up of persons with disabilities themselves. They can be really valuable in terms of identifying who people with disabilities are, where are they living, and also supporting us with making those processes more inclusive. I'm not going to go through all the tips now because you can read those in detail in the guidance. If we can just go on to the next slide. Yep. So in terms of good practices, one of the things that we saw coming out in the 2020 HNOs was a recognition and explicit acknowledgement in 63% of the HNOs of the need to strengthen the collection and analysis of data. And we found this really valuable because it helps to bring more priority to this issue. We saw this in, for example, Central Africa Republic, Burundi and Niger, this explicit recognition that disability needs to be better integrated into needs assessment processes and that there needs to be strengthening of data collection on disability. Next slide, please. So I will hand over to Kim to take us through some of the questions and reflections we're seeing in the chat. Kim, over to you.
Thanks a lot, Kirsten. It's been a relatively quiet group today. As you noted, there was an interesting question about how to estimate the number of persons with disabilities in situations where in data poor situations. And so that 15% estimate is what is recommended. Some additional suggestions were put forth where that could, if the belief is that those numbers, the 15% may be underestimating, certainly stating the global prevalence is advisable, but nuancing it with regional evidence from countries who have also been in protracted crises, such as Syria, as this data might be more indicative of prevalence in places such as Yemen. Some really helpful additional comments coming in from participants on the chat. We have something in from Maria in Somalia in terms of collecting data and information from on disabilities. With the challenges posed by the ongoing COVID pandemic, including movement restrictions, how might it be possible this year to collect data through interviews? And she surmises that most countries will do phone interviews. Are there any other good examples? So this one I'm going to throw out to the colleagues because indeed it would be very helpful to get a sense if there were new creative ways that were being used. To my knowledge, the telephone approach is the one that is most commonly being used, but I think it's pretty obvious that that will have limitations. So can I throw this out there to the group to see if there are suggestions or ideas or experiences that might speak to the question that Maria has posed? Throw them out there.
Hi, Kim.
Hi.
Hi. For the example, actually, I just sent on the group chat that Washington group themselves have sent a very nice guideline, very short guideline about how we can collect data during COVID-19, focusing on phone interview because this is mostly will happen. Also, we have some experience. David have already tried this type of collection of data, and several organizations, Handicap International, UNICEF, we are ourselves have done that also. It's a very challenging issue, but it's not impossible, and it could be done in very good way if we take care of a specific few issue. You will find it in the document that I have sent it, but we need to ensure that the sample is not biased because, as we know, not all people have phone, and also not all persons with disability have access to phone. So we should be careful because the problem could happen at sampling starting. Also, we will have we need some consideration about how we will ask the question, if we will ask the question directly to the person with disability or one of the household member that could answer. And as we know that when another family house member answering question regarding disability, usually the prevalence is decreased. Sorry. So we should take care. Accessibility of the telephone itself or electronic way of collecting data should be considered also. But this will not prevent us, of course, to work on that. Thank you.
That's very helpful, Ahmed. Thank you very much. Do we have some other either ideas or some questions?
Yeah, just to add, hi, Mali here again.
Yes.
Syria, yeah. I mean, just to add to that, we're working on, the MSNA at the moment, and I think it's just really important to, acknowledge that the methodology this year, in the context of COVID, is not going to be ideal, and I think just making sure that it's detailed very well in the methodology what the limitations were to your data collection, etc. But also working with agencies such as REACH, for example, if they are the organisation responsible for data collection in this instance, around making sure that all persons with diverse difficulties have equal access to participate in the survey, and offering training and input in terms of how to make the actual interview, if it is done remotely, accessible, and what kind of accessibility measures that organisation can employ to ensure that persons with difficulty hearing, communication, etc., are able to access the interview on an equal basis. And then also thinking about, if you are doing household level data collection, and thinking about how you can modify your methodology to focus on the head of household reporting, and facilitate a household level data collection exercise, again, just taking into account some of the limitations that come with that methodology. I hope that's clear.
It is, and in fact, indeed, it's a very complex year. I can tell you that in some discussions with individuals who work on gender-specific issues, they've taken issue with us suggesting that household-level data collection could be used in the way that you were promoting, because when contacting heads of households, it tends to be, in many contexts, the male head of household as opposed to the female head of household. So there's concern that some of the approaches that we are suggesting may be used in light of the COVID-19 situation might have negative backlashes to other subpopulation or population groups. So I don't state that in any way to disagree with you, just simply to encourage those who are looking to this to be aware of these other elements that need to be taken into consideration, to be aware of them. And in fact, in the HNO for this year, we do clearly state that it is assumed that The nature of data collection, the nature of the data that will be used for the humanitarian needs overview is likely to be very, very different. We assume there will be less primary data collection and an increased reliance on secondary data, noting that some of the time scale of that data may not be ideal, and an increased reliance on expert judgment and expert knowledge. We've been advocating for increased engagement with local organizations, and included with that would be local women's organizations, local disability organizations, where we would assume there is significant knowledge and expertise that could be drawn upon, even if it is not necessarily, you know, quantitative in nature. So some creative thinking will definitely need to go into it this year. I think I have one more minute, so let me see. There are some other points that came in.
Kim, this is David. I had a question to
Yes,
Kirsten on
please.
disaggregation, and I wonder if now is the right time or if it will come at a later stage.
Sorry, did you say on data disaggregation?
Yes.
Why don't you pose it and we'll see what we can do.
Okay, so I hear about the need to disaggregate data looking at disability, and I wonder a little bit, I am puzzled on how should we best do that, looking at two extremes. Suppose that I make a golden rule that every time we need to count a population, be it in terms of needs or a target or a result, I want to disaggregate. But I also want to disaggregate by age, 3 categories, by gender, 2 categories, disability, maybe 2, maybe more, the status of the population, sometimes 3, sometimes 4. If I multiply all that for one figure, I need 36 figures, and it's impossible. So my question is, how much do we want to actually, every time we count people, disaggregate by all those criteria? And how much can we be satisfied by saying, for this target population, I need a clear understanding of its status looking at disability, and that will then drive the response that is given to them, but not making it a golden rule that every time you count, you have to disaggregate. So how do you go about between those two extremes?
Maybe just to add to that as well, I've been processing the same issue. Where it comes to disaggregation by disability, we have the very obvious categories of the physical that you can actually see. There are others that probably need some medical determination to say in which category do these fall. Yeah. How does one bring all that complex situation to the data analysis, the data collection that one is undertaking?
These are complex questions that you've posed to us. I will look to my colleagues to see if they have a relatively short and quick some insights that can be shared. And if that's not possible, and maybe something that we need to take off on the side and address some questions after the fact, because this does go into quite a level of detail and complexity, but I recognize that it is also a critical and pressing issue. So could I look to Ahmed, Kirsten, Steve to see if you have any sort of quick bullet insights that could be shared on this?
Thanks, Kim. Sure, it's Steve. I'm one of the helpers in UNICEF. One of the key points, I think, in terms of disaggregation of data that's important is, I know Kirsten mentioned the Washington Group set of questions earlier, and it gets into some level of detail about different kinds of disability. One thing that we should think about, though, is that it's not necessary to disaggregate to that extent in terms of types of functional limitations that people have. It's sufficient to say, in order to raise the profile of the issue, to try to kind of quantify the number of people that might have some form of difficulty, and then to dig deeper at a later stage as you begin to design programming, to sort of look at those intersectional inequalities and say, okay, you know, the children that are disabled, what kinds of issues in terms of access might they have for this educational program, for example, that we're setting up. So I wouldn't say that the expectation is to disaggregate 6 different ways for every respondent. As you mentioned, you're already looking at gender and age and other kinds of disaggregations. It's not necessary to go into a sort of an exhaustive analysis of the forms of functional limitations, if that helps. Does that help?
Yeah, I think to me it does. Yes, thank you.
Yeah, can I jump in there? Sorry, it's Marley again. Just a different perspective. I think that it actually is really useful to disaggregate by functional difficulty, and the reason for that is by gender, age, and functional difficulty specifically. And the reason for that is that, you know, we understand that various groups experience barriers in a different way to accessing humanitarian programs. So a really obvious example would be livelihood. And from experience working in inclusion in livelihood programs, what we were finding when we failed to dig deeper into the various difficulties that our population group were experiencing was that we were able to engage a lot of working aged men with physical difficulties who were still largely mobile but had some difficulty. And then so what we realized was that, you know, we weren't being inclusive to a significant extent because we weren't understanding the needs of persons with other types of difficulties such as intellectual difficulties, visual, etc. And so I think for programmatic purposes, I would advocate that it is really important to understand what kind of difficulties are most prevalent in your population. So then you can program really specifically and you can plan in terms of your universal design, of course, but then also your particular types of reasonable accommodations that you may need for your particular project, and build that into your project, and also be able to allocate funding, etc., for those types of accommodations that may be required, which also has ramifications, you know, in terms of procurement, etc. So I think in terms of planning, from my perspective, I think it's just another opinion. I think it would be useful.
Thanks very much for both of those. I think the two of you may have been speaking at different levels. So if we're talking about the HNO, it tends to be more of a strategic and higher level, whereas if you're talking about programming or planning for organizations, you would certainly need that more granular information would be of significant benefit in the ways that you mentioned for procurement. So if we're talking about the joint intersectoral analysis framework and the HNO at the more strategic level, we would not expect that level of disaggregation to be used. However, when programming, certainly should that data be available, it would be of significant value to programming and planning. Ahmed has added one point into the chat where he's put a link to the analysis to the disaggregation, and then to think about why we disaggregate and what that information will actually be used for, and then whether or not what level of disaggregation would be required to fulfill those information needs. With that, I realize that I have taken this little session over what I was allowed to do so. But I think that it helps us to transition very well to the next question. So I thank you specifically, Marley. You know, in theory, we've got our HRNO, we've got a robust analysis that's been done, you know, jointly looking at things from an intersectoral nature, the relationships between the needs of different population groups, subpopulation groups, and takes into consideration the intersectionality and, you know, the dynamic identities that every individual has. And now we need to program according to it. We need to develop our HRP, our cluster sector programs, and our projects. So how do we include disability in the HRP process? And with this one, I will look to Ahmed, please.
Thank you, Kim. Thank you. It's a very interesting discussion. Moving to HRP, and the one and the most important issue moving from HNO, HRP, that we need to show that the analysis that have been explained by my colleague Kristen will be reflected strongly in the HRP. During the analysis that we have done in the last 2 years to HNO, HRP in different countries, one of the most weaknesses we can see in HRP when we don't do anything with the analysis or the information that collect on the overview, and we cannot see the link of what we have discovered as a critical problems in HNO, and this is not reflected in the response as a solution. I will have here go very fast on identifying response option as one of the basic step of HRP, and here it's very important to link the critical problem discovered in HNO. For example, if we are talking the example of WASH, considering our current situation, we usually discovered in the HNO that persons with disability have limited access to WASH facility due to physical barriers. This is even before COVID, and it's happened in most of the humanitarian context issues. And if we have found that in the HNO, it makes logic that we will design a response to work on that. In this case, improving physical accessibility of WASH facility in consultation with person with disability, or even we provide specific services as we will mention in a minute. So it's the first step to identify exactly and to understand that it's not only a specific solution to specific problem, also to be able to link this problem together, to understand how we are working as a multi-sectoral approach to solve the problem. So this is very important also to consider. For example, having a WASH facilities could be linked to the protection due to GBV problem or protection problems that we need for girls with disability who are heading to WASH facilities, for example, during a specific time of the day. So having a holistic approach that is logic in the same way of understanding the critical problem and design a response for it is very important. The second step that we also see in HRP, that when we have done our analysis, we have discovered a lot of good practice. For example, in Somalia, in HRP 2020, there was acknowledging of that there was a need of effort to identify barriers, risk, and enablers for people with disability, which is a very good point. And actually, in our working group, we was discussing that. It's not only, disability is not only about disability itself, sometimes it's about enabler. So it's not about barrier, it's about enabler. So we should look to what is negative, what is problem in the environment, and in the same time, we should look to what could help persons' ability to reach, what can enable them to be more, having more access to humanitarian response. Also, acknowledging that we need to strengthen the inclusion of people with different type of disability, acknowledging that this could not be happen without additional resource to be allocated, as one of the comment on the chat was highlighting that resources needed to be allocated to inclusion, data collection, partnership with organization of persons with disability, nothing about us without us, and also and reporting. One of the good practices in Somalia that they have disaggregated disability data in 75% of their project to see to which extent they are able to targeting and ensure that a person with disability have access to this project at least at output level, as we will explain in a minute. This actually is linked to a very important approach that I'm sure that you're already familiar with it, which is a twin track approach. We have just talked about it and we keep coming back to it, that inclusion of persons with disability should be linked to the definition of disabilities that have been discussed by Ricardo. As we are actually dealing with a complex system that is leading to disability between the impairment that the person having and all the personal and physical context that is living in, actually and how we interact with the environment, we should design our response to cover these two parts. We should design our response to have a mainstreaming part that is designed to ensure that persons with disability have access to facilities. For example, the same example that I have used, washing facility, having a physical accessible wash facility to ensure that person with physical disability can access it, for example, and having a target response. That means that sometime I will need a specific response designed only for person with disability. For example, having an assistive or providing assistive device that will allow person with disability to access to food assistance or wash facilities or whatever. So this is very important to ensure that in our response, we are balancing between ensure that all our action is accessible for persons with disability, and to ensure that we will support them by targeted and support services that will allow them and focus on specific needs that they only have, for example, rehabilitation, assistive device and technology, and so on. Moving to the second part of the HRP, and the most importantly about monitoring and accountability. Actually, this part of HRP are always one of the weakest part regarding disability inclusion, and we need to understand that without having disability inclusion well represented in monitoring and accountability framework in HRP, it will be very difficult to ensure that what we have written inside the document will be translated on the ground. So we need to ensure that disability are included at two levels. The output level, that means usually that is focusing on addressing critical problem for person with disability. And in this case, we will need a specific indicator to target this, as we have said in the twin track approach. For example, number of person or staff or partner or community training to working with person with disability, or a number of persons with disability who have access to specific rehabilitation services or assistive technology. So we put a specific indicator targeting to measure the output for persons with disability. But also at outcome level, which is usually covering mainstreaming services, we need to ensure that there are some indicators that show that persons with disability have equal access opportunity for the services as any other group. For example, if I have an indicator saying that number of girls and boys benefiting from distance learning program, and as we know, this will be a default in our HRP due to COVID in most of our HRP, we need to ensure that this is disaggregated by disability. And again, this is linked to the very important question have been asked about when and how I can deal with the disaggregated data, and how I can deal with overwhelming requests for segregating data. You need to be strategically thinking when and how and why you are segregating data. And this is a good example for that. If we are sent that person with disability, and in HNO sense that person with disability or children with disability don't have enough access to learning program, either distance or Monday or face-to-face, it makes sense that we will design intervention and response that will deal with this problem, either at the level of the children with disability or the level of the system or the mainstream service. And it makes sense that we disaggregate the indicators that is measuring the access to education in general by disability. This is very important to cover, and I hope this is a good example of the disaggregation there. So moving along that, we need the outcome. I will leave it here to question and thought. If you have question, please send it to the chat, and we can discuss as we discuss in HNO. The taking out message from that HRP need to be linked directly to HNO. We need to ensure that the HRP is focusing on twin track approach in the response, and we need to ensure that the accountability and monitoring system is considering persons with disability, their opinion, they have a participation, and they are able to choose the solution or the response that is fit to them. Thank you.
Thanks a lot, Ahmed. We are definitely coming to our last few minutes. Are there any burning questions? I'm not seeing anything coming through in the chat, and we are just about to wrap up. So, but I don't want to close anyone down. Okay. I'm
And
not. Please. Hi.
Yes, I just observed the slide before the very last one that we are now looking at, where obviously disability is the key issue that is of concern to us that we are talking about today. But the disaggregation, to the extent that I assume, should be beyond just the disability, even though we know this is the issue of concern today. But on the monitoring and the accountability slide, what I notice is that it's probably just the third bullet of boys and girls, which means it's not just disability, but it's also the dimension of boys and girls. But all the others look like we're just referring to persons, to people. Does that mean to say that then disability, where we are bringing it in, overrides the other aspects of disaggregation? Or is it still important that even though it gets increasingly complex, that we should consistently say men, women, boys, girls, but also by disability? Maybe it's just a comment.
Yeah, thank you. Of course, I will ensure you that the idea here, because we are giving example and we're giving training for disability, we highlight disability on the slide because unfortunately we don't have a space and time to cover everything. However, I highlighted this in HNO, HRB, the guideline and the template is clearly saying that the segregation should at least cover gender, age, and disability, and you can find it in the template and the guideline. However, even this is not enough. As I said, it's very important to ensure that we are thinking twice before we disaggregate data. Yes, we know that these groups, age group and gender groups and person with disability group are among the vulnerable communities or population in the communitarian context, but sometimes we need to have more in-depth analysis, refugee, specific ethnicity, specific, and it will depend on the context that you are segregated data. So it's not an automatic answer. Usually it's linked to what you find in HNO, link it to what is your BIN, what is your population in need, and what is their characteristics that you discover in HNO, and what you will target. And based on that, you are choosing how and when and why you will segregate. So I confirm that it's a very important part. And there are a lot of guidance you will see in the guidance that I have sent it, and in the end of this that is completely discussing that in more details, of course. Thank you.
Thanks a lot, Ahmed. And Murat added an interesting point in there, which is data disaggregation in itself really adds no value to our work. It's how that's analyzed and how that's used. So over the past few years, we on the gender side, we've seen increasing improvements because the data that was disaggregated is now actually being analyzed, where even just 5 years ago, we were starting to see data and it was sitting there. So we're not saying don't disaggregate, we're saying disaggregate in a thoughtful way and use the data for analysis and for programming. Do not just disaggregate for the sake of disaggregating. And with that, I'm afraid I'm going to have to hand over to Kirsten, and with the question is obviously there are going to be more questions that are arising, and there's a desire for more information and increased learning. Where can people access more information, and what is next? Over to you.
Great, thanks, Kim. I'll ask Ahmed to, yes, bring us to the next slide. So what we will be doing is sharing this slide, the whole PowerPoint, with everybody. And I won't go through this guidance one by one just because we're quite limited in time. But when you receive the PowerPoint, you'll see that there's quite a lot of useful guidance here that you can go through. I'll just highlight in particular that very first one, the guidance on strengthening disability inclusion in humanitarian response plans. That's what we've taken the content from today's training from. So that's where you can find a lot more detail on what we've been speaking about today. I will leave it there from myself. I'll quickly hand over to Steve on the what's next. And thank you everyone for your time today.
Thanks, Kirsten. What I'd like to do is to offer a follow-up exercise and to offer a follow-up training to country teams to help them through understanding how to be more inclusive in terms of disability. Ahmed, could you show the next slide? What I'd suggest is that as country teams, we do a bit of homework over the next few weeks. What we would do is homework in a self-organized, independent way. What we would suggest is that people working in particular contexts and given humanitarian country teams sort of get together for a few hours between now and the end of August to try to contextualize the issues that we've been talking about today in their own local situation. The idea is to localize and contextualize topics covered in today's session. In the next slide, I'll show 3 topics that I'd like you to give some thought to. These 3 topics are aligned with the HNO and HRP process that's ongoing. It's not really extra work. It's just, you know, building on the foundation of today and extending it a little bit to the work that's ongoing. If you engage in this and give us a sense of how it's going in your HCT, this would provide a kind of context for us to build additional technical assistance needs if required. And it would also give us a kind of context that would be very helpful in designing a session 2 training to answer very specific contextual questions that you have. Ahmed, can you show the last slide? I promise, the last slide. So this is the follow-up exercise for country teams. We have 3 topics. We suggest that each country team try to engage on each of the topics. The first one is this: identify 3 to 5 key questions about the situation, needs, and priorities of persons with disabilities that you feel should be answered by the 2021 HPC needs assessment process that's going on in your country context. So identify what 3 to 5 questions particular to persons with disabilities should your HNO grapple with. Second question, in your local context, we would like you to reach out to a local organization of persons with disabilities, an OPD, or another kind of representative group of persons with disabilities, to understand better their role, who is involved with it, what their membership are, what kinds of opportunities are possible for them to engage in the response. In other words, we'd like you to go out and shake hands with the local OPD to see how they maybe could get involved in the work that you're doing. And the third topic that we'd like you to grapple with is this idea of the twin track approach. What we noticed in the 2020 HPC is that we did quite a good job on the HNO side to identify the needs. Where we fell a little bit short last year was sort of linking that analysis to actual response plans. So what we would like your HCT to give some thinking to is describe practically how this twin track approach could be applied to your 2021 HPC response plan. What kinds of things should be mainstreamed and all across the entire program? What kinds of things are more specific to persons with disabilities and requires a more tailored approach? So these three questions we would like you to give some thought to. We don't think it's too much of an additional burden insofar as the process is underway. It's sort of an additional depth to what you're already doing. We expect it would take a few hours. We would encourage people to work together or do it individually. And if you could feed back to Ahmed how you've come to terms with these three questions, we would use that in the development of a follow-up training. We'll provide more information on this in a follow-up email this week. If there's interest, we would use our list of people participating in these sessions as a way of connecting you up with other people in your local context. Back to you, Kim, for a final wrap up.
Thanks a lot, Steve. With that, my last words are thank yous. Specific thank yous to the facilitators, to Kirsten, Ahmed, and Steve, who again put together the content, the facilitation. Their expertise in this area has been invaluable to us. And our thanks to all of you who joined us at somewhat strange times for some of you. I know everyone is incredibly busy, but we appreciate that you also recognize the importance of this topic. As always, should you have any questions, please do feel free to reach out. If it's something that I cannot answer, I will certainly direct you to the appropriate person or endeavor to get that answer for you. And we will be sharing the links to the Zoom presentation, the audio files, the transcripts with you, as well as attempting to hook you up with other individuals in your local area so that you can work collaboratively. With that, I will close. I realize we're a few minutes late. I thank you and I wish you all a wonderful day. Take care. Bye-bye.
Mm-hmm.